This is a documented training program for three-dimensional spinal biomechanical correction of a patient in the X, Y, and Z axes. The very first thing that we're going to do is evaluate her posture on the X, Y, Z axes prior to adjusting her. So we're going to do that right now. And Cindy, if you'll just close your eyes and flex your head forward all the way. Remember what that feels like. Now backward all the way. Yeah, see that kinks right there. You always pay attention to what the patient's range of motion looks like. Take a deep breath in like she's doing and relax. You always have the patient keep their eyes closed so that their posture actually deviates to the biomechanics of the spine as they are right now. And I can tell that she's still sleeping on her side, which is normal for her. But it does cause her a lot of cervical, thoracic, as well as pelvic pain. But she's improved a great deal in her posture from when we first started. So that's great. Now I've analyzed her from head to toe. She works on the computer all day long and sits for 8 to 10 hours a day. So she has a great deal of anterior weight-bearing forward head posture, which is positive SZ cervical. So what we're going to do now is I'm going to take her over and I'm going to decompress her spine on the y-axis. And this is exactly how you set the patient up and put the towel around their neck and do the spinal decompression itself. So we'll do that now. Cindy, if you'll go ahead and just lay on your back for me, please. And when we do this, to make the patient more comfortable and put them more at ease, we have them come down and get lined up first. And then this button right here raises the legs up and relaxes the lumbopelvic spine region from the sacrum all the way to the occiput. Now you notice I have her legs at a 90-degree perpendicular angle here, but the bottom part of her legs are parallel with the floor. When we do that, it changes the entire angle of the pelvis, flattens the lumbar spine out, so that we get total relaxation as much as possible in the supine position. The very next thing that we do, before we pin the patient in, is we take a wet towel. And you notice this one is a kind of a tore up towel, and I did that on purpose because I get a much better grip around the patient's neck. And the towel is very thin, so you can see that there's not much width in the towel itself. Now I put this towel directly under the patient's occiput, there you go, and I leave it right there for now. And now we bring in the stabilization pins. These are very important to put right on top of the iliac crest on both sides. There are little holes here in the table that allow us to fit the patient in perfect for their size. Now Cindy's lost a lot of weight, so we're able to get her in to a lot lower pegs than we used to. So she's doing really well on that. And I'm trying to get that in. Now you get those pins placed in there nicely. You want to make sure at this point that the patient's just relaxing and breathing normally through their nose and thinking good thoughts and relaxing, not thinking about anything. And you watch their breathing, and it's just a very high velocity, low amplitude, straight pull on the y-axis. She couldn't go anywhere because I had her pelvis pinned in here, which is exactly what stabilizes the spine for me to decompress it. Now, we got movement in her spine from her occiput all the way down to her sacrum on that adjustment alone in a split second. This is great for herniated disc, bulge disc, degenerative discopathy. I even do this on patients that have fusions with instrumentation, because the fusion itself doesn't move. The areas above and below that move, but fusion does not. And you can also do it on patients. I do it on a 76-year-old lady that has degenerative bony fusion, and it's the only thing that takes the compression off of the nerve and decompresses the spine on the y-axis. Now, I always do the reflexes afterwards because it's real easy then. The patients have a comfort level. A lot of times you can do the reflexes prior to the adjustment and then post-adjustment and see a big difference. I usually leave the patient on the table for a little while, and I make sure and adjust their feet and ankles and toes all the way down, because she's had some lumbar radiculopathy from a herniated disc at L4 and L5, which she has already seen 4 or 5 other chiropractors in the past that have just done traditional lumbar rolls, which I do not do on her at all. But we get her relaxed there. Now, while the patient's legs are still up there, we just remove the towel, take that back over and keep the camera on her. And then I'm going to come back. And I already know from her posture and previous exams, plus my palpation right now, that she has a atlas right here on the right, which we just got. And you notice I'm not rotating it as much as I am driving it lateral in the x-axis. Now, another thing that we have issues with Cindy on is her ribs and her upper thoracics and mid-thoracics from working at a computer all day long. So before I do the anterior adjustments on her thoracic spine and her ribs, I always make her get up sideways. So go ahead and get up, face towards Johnny. Well, you face this way. That's fine. There you go. Get up whichever's easiest for you. Okay, watch these pins here and get these out of your way. Okay. Now, I'm going to adjust her shoulders. And I always pull the bicipital tendon back into the groove. And her shoulders are doing a lot better. They're not clicking like they used to. And then I adjust the glenohumeral joint. Same thing on this one. This one's not nearly as bad. There we go. And I always get the entire pathway of the cervical brachial plexus all the way down, including through the carpal tunnel, all the way down into the fingers themselves. Many doctors, chiropractors, do not adjust both the cervical spine and the wrist, which is oftentimes double crush syndrome, where they actually are impinging on the nerve in the actual wrist, which is the carpal tunnel, the median nerve, as well as the cervical brachial plexus. So when you're pinching the nerves in here and here, that's called double crush syndrome, and patients often will get reflex back and forth. If you're not fixing both of them, you don't get the problem. So next thing I'm going to have to do is sit back up on the table. And let's scoot up this way a tiny bit. There. Now, I'm going to have her cross her arm here. Her other one way up on top here. And I always have the patients bend forward all the way. Take a deep breath in. I'm going to lay her back. Perfect. Excellent. Now lay your head back and let your ear out. There we go. Got it on that last one. Now, also, I like to adjust the entire hip joint itself, which goes all the way up to the hip joint. Perfect. Now her legs are exactly even coming down. And now we're going to go ahead and have her get up sideways again, whichever way is easiest for her. She knows how to get up. Observe how she's getting up sideways. You don't ever want the patient to sit right straight up after this adjustment. So now we're going to have her come over here and lay on the BioPhysics table and adjust the Z and the X axes as well as some of the Y axis. Okay, so let's have you lay on your tummy first. And of course I do a leg check on the patient every time. Now her left leg is only short by about 1/4 of an inch. She does have a positive knockless test, which increases the pain and tightness in her pelvis. She also has a positive Deerfield on the left. And so, therefore, she has sacroiliac subluxations right down here on both sides, which I know she feels. So we're going to adjust the sacroiliac joint on the right first. There you go. And that's in the X-axis and the Z-axis. Now you'll notice I'm adjusting her left sacroiliac joint differently. And now I'm adjusting her sacrum straight S to I, superior to inferior on the Y-axis as well as the Z-axis. Come right here on L5. Just wait for them to get there in their breathing and relaxation. There we go. And I always have to catch some patients between bucks, which is great. I like it when they laugh, because then I really can catch them. There we go. Everything's moving great. Perfect. Now, because she's got so much pelvic distortion and subluxations in her thoracolumbar, lumbosacral, and sacroiliac regions, I do a lateral stretch, oblique stretch, all the way up into her thoracic spine, and oftentimes we'll actually get some rib movement all the way up. Now, right here in Cindy's thoracolumbar region, there it is, perfect. That always is very tight, and a lot of times we don't get that first thing on the interior adjustments, just because that's a very tight hypertonic area in her thoracolumbar spine as a result of her sitting so many hours a day. Now I do a lot of trigger point therapy, myofascial release. Her gluteus medius and maximus, as well as her piriformis, are very tender. I also do transverse friction massage on their tensor fasciolata muscles bilaterally. Now again, she's got some really big trigger points in her gluteus medius muscles, maximus, and then, last but not least, that deep piriformis muscle. And again, even though it smarts, you've got to get in there and do a transverse friction massage on the tensor fasciolata muscles. And a lot of times, you watch out because they can kick you in the head on this one. Now, we just love Cindy's socks. She's got some really cool socks every time. So it's fun evaluating her length. Now see there? Much less on the knockless test. Deerfield's even, legs are even now. So we know we've got a good post adjustment there. Now I work myself up into the cervical area, and we find that she's got trigger points in her trapezius muscles, levator scapula muscle right here, and at first I'll use my thumbs because they've gotten quite strong and pancakey looking over the years, and she's much worse on this left side here, but then we start getting down into the rhomboids here, which is one of the areas that she has a great deal of problems with, the ribs and the thoracic spine region, and those are very tender. There we go. Now, the other thing that she's going to have is really tender teres major problems, which is affecting her entire shoulder girdle area, especially, man, on both sides really, but the right one's especially tender today. I know these are sore, and I try not to get in there too deep, but you do want to stimulate those every time and try to get them calmed down, because if they stay hypertonic, they'll just pull the patient out much, much quicker. So now, what we're going to do is we're going to get her back up and reevaluate her posture. I'll bring it back to the other. I'll bring it back to the other. We don't want to get that noise in here. There we go. Now, we always caution the patients to take it slow when we first do this, because this is a very dramatic adjustment. And what I'm going to do here, the very last thing, which I always do on every single patient, is I use this Atlas adjusting instrument, and I don't know if you can get this on the video, but is a very high velocity, low amplitude adjustment instrument, and I'm going to adjust her atlas on the right, which has gone lateral on the x-axis, putting her in a mirror image of her current biomechanical configuration, which is probably already improved since we checked it the first time. So you just stand right there. Spread your legs just a little bit further. You want to have the patient spread their legs a little further apart here, so that we can get a good grip on them, and if we have to put some pressure on them, that way they can stand up without getting off balance. So let's close your eyes, flex forward all the way. Much improved range of motion, not only in full range of motion, but also the smoothness of it. Take a deep breath, relax. Now, as you can see, her improvement is tremendous on her x-axis here, but she still has the forward SZ as well as the positive theta X cervical. So we're going to treat that by pulling her shoulders straight up first, and then hold them back. Bring the arms straight back. Now I'm going to bring her head straight back in extension. I'm going to translate it. Now she was rotated to the right because of how she's sleeping. So you notice I rotate her back to the left, and I adjust the atlas right here. I adjust the atlas on each side, and I also adjust the sacroiliacs bilaterally. So now, after we do that mirror image atlas adjusting, we're going to have her do her posture one more time. Okay, flex your head forward all the way. See, much smoother, much straighter, much smoother. Take a deep breath. There you go. And as you can see, much, much better posture. There's only one little thing that I need to do, and that's right there. And that will correct her three-dimensional distortions. Go ahead and flex forward again. Backward again. Excellent. Take a look. Did that feel smoother?
Oh, yeah.
Much smoother. Good.
I could tell.
So this is a complete three-dimensional spinal corrective care BioPhysics adjustment, utilizing decompression for the y-axis, the x-axis, the z-axis, and then finishing off by recalibrating the cerebellum, which controls balance, posture, coordination, and all kinesthetic movement. When I adjust her atlas in a mirror image, the brain, the cerebellum, the hindbrain, reorganizes all of the neurology coming from the brain down to every organ, muscle, tissue, and cell in the entire body, and allows her body then to get back to a three-dimensional weight-bearing posture that is strong and stable with gravity rather than weak and unstable with gravity, which is what causes spinal degeneration, degenerative disc disease, and most often disc bulges and or herniations of the disc. So thank you very much, and we always give our patients a hug and love them. And that completes our training video on three-dimensional spinal correction. Thank you for watching.